Welcome to A Window on SAHMRI, where we take you inside South Australia's independent not-for-profit health and medical research institute. Each episode, we get to know the people driving our life-changing research, getting into what motivates them personally and how their work is delivering a brighter, healthier future for all. Stu, you've been focused on visceral pain and inflammation for the past 2 decades or so. What is it about this area of research that's kept you so enthralled?
Well, visceral pain is such a massive clinical problem around the globe. You're talking about probably 25% of the global population who suffer from some sort of abdominal and pelvic pain. And that includes conditions such as irritable bowel syndrome, inflammatory bowel disease, bladder pain syndrome, and for women, endometriosis. And the really big issue is that there's been a complete lack of cures and treatments for these conditions. Now, all of them are characterized by chronic abdominal and pelvic pain. If you talk to an IBS patient, they say, well, you know what it's like if you've had food poisoning and you're just doubled up in agony. You need to find where the bathroom is. You don't want to socialize with anyone. You don't want to go out. Well, imagine living like that on a daily basis for years and potentially decades and having no way to treat that. So really, that's the reason why I've been so interested in this area, because so little is known about what happens within our internal organs in a normal, healthy situation. And then crucially, what goes wrong to cause these chronic pain conditions.
Why do you think there is so little that's known about it and it's lagged behind?
I guess it's complicated. It's our internal organs. We can't see them, without diagnostic tests and imaging. And I think it's one of those scenarios, particularly with pain. If someone has an injury, you get they're in pain. So if someone rocks up and they've got their arm in a cast and they've broken their arm, people will think, okay, there's an injury, they've got pain.
It's obvious.
It's obvious, yeah. Whereas a lot of visceral pain, it's not obvious. It's certainly not obvious to the other people. And it can also be not obvious to the clinician when these patients rock up and say, I've got chronic abdominal pain. I've got all these other symptoms, what's going on? And it's only through, the research and the knowledge that's been built over the last couple of decades where we can sit back and say, well, look, there are all these changes which are happening within the periphery. There are all these changes which are happening within the spinal cord and also within the brain. And they all work together to underlie these chronic pain conditions.
And where does stigma factor into it, especially for a condition like endometriosis, where for so many decades, so many women live with this pain and it wasn't credible? Doctors would say it's in your head or you just have a low pain threshold and you have your period and get over it, basically. How does that affect research?
It's been a massive stigma. I mean, if we think of something like inflammatory bowel disease or irritable bowel syndrome to start with, which has sort of been researched for a bit longer, then you go back 20, 30 years and this was all in the patient's head, particularly with patients such as irritable bowel syndrome. Because you can do a colonoscopy, you can do other tests, and nothing really appears like it does for inflammatory bowel disease, where there's clear inflammation, there's clear damage. There's something there that makes sense. There's an injury which therefore causes the pain. But what we know now is that there is rewiring of the pain circuitry, which happens following healing of these events. So it is all about the previous stigma. It is also about, an education process and understanding what's going on. Because, a lot of these patients, endometriosis sufferers, for instance, 7 years to get a diagnosis, living in pain for 7 years, having to undergo a variety of different tests, including endoscopic surgery, to characterize and diagnose the condition that they've got. And then even within that diagnosis, there's a heterogeneous population of sufferers within that. So it's incredibly complicated. So the more we know and the more we research, the more we're understanding what causes the pain in these different scenarios, and therefore how we can have pretty much, if you think about it, personalized strategies for those individuals.
Because the first step is accepting that there is a problem that needs solving. And until that's on the table, we're not going to be throwing the necessary resources at it to actually make that progress. And it seems like for those conditions, that's really been the last 10, 20 years that we've even started really working on those. Is that accurate?
And really, I think understanding and appreciating what's going on. Again, if we sort of go back to irritable bowel syndrome, IBS, you go back 20, 30 years ago, it was just lumped together as one condition. These patients have chronic abdominal pain. They might have, altered bowel movements, so they have diarrhea or constipation, and they were just kind of all lumped together. But the more research that's been done at a clinical level and a preclinical level, it's clear that there are different subtypes. There are some types of patient who have pain with constipation. There are some subtypes who have pain with diarrhea. There are some who have pain and alternate between the two, and some are unspecified. And the work that's being done shows that there might be different mechanisms, different etiologies, different underlying causes for this pain and this condition. So that means if there's different underlying causes, you're going to need different underlying treatments as well to look at that.
It must be one of the real challenges with it, because one condition presents a lot like another condition, but it's not that one.
That's right.
And then vice versa. So people might think, oh, I've got IBS, but they've actually got endometriosis, or the other way around, or they might have both, or they might have neither. It might be something else. And there's so many symptoms that could be anything. And I suppose a lot of people doing self-diagnosing too, because there's also the embarrassment factor for these kinds of conditions too, where people don't really want to make public some of these struggles, and that would factor into them not going and getting help. And then also in a lot of cases, there hasn't really been much help available.
Well, that's exactly right. And, a lot of people don't want to talk about what they have to do in the bathroom. Oh, I've got to go to the toilet, 15 times a day. It's a taboo subject, or at least has been historically. Whereas, I think the more we find out, the more we educate people, and we sort of say, well, look, there is actually an underlying condition going on here. This is a real problem, and we're starting to understand what is causing it, and we're finding new ways in which to treat it.
And is this something that you've experienced in your own life, or people close to you have, in terms of visceral pain?
I mean, I haven't experienced visceral pain per se. I've certainly experienced other forms of pain, and it's not pleasant. I know people who suffer from a variety of different types of chronic abdominal and pelvic pain, and you realize what a misery their life is, and what a massive issue it is. Not only in South Australia and Australia, but globally as well.
How does it affect people over time?
Well, I mean, if you think about the condition, one of the ways in which this starts, or is thought to start, is through a gut infection. So normally we might eat something, have food poisoning, something like that. We might be sick for a couple of days. Most of us might recover normally, go back to a normal life. For a lot of people who suffer from chronic visceral pain, that system doesn't reset. So if you think about, from a point of view of, say, our hands, if we smack our thumb with a hammer, or we burn it on a hot kettle, we know that's painful. That's a protective mechanism. That lets us know, well, next time, maybe let's not do that. And of course, for a few days afterwards, that tissue is therefore sore. So whatever you do, you try and pick up a cup or something, it'll hurt. And that's a protective mechanism, so you don't do more damage to it. But for people with chronic pain, that sort of alarm system doesn't reset back to normal. The pain system is essentially an ongoing false alarm, or it might actually be triggered by something which is chronically changed. And that's really what we're finding with these patients with chronic abdominal and pelvic visceral pain, is that there are changes that happen, particularly within the nervous system, the immune system, which is driving these ongoing pain signals. So if we can reduce that or block that, it's a good way in which to treat the pain. Treat the pain at its source and block it at its source.
So it's like there's a glitch with that warning mechanism.
Exactly. A lot of our physiological processes, and pain is a normal process. It tells us something. But if that doesn't go back to the way it normally should be, that's when you have a problem. That's when you have symptoms. That's when you have these conditions.
And how does this impact people mentally, especially? Because I would imagine chronic pain that doesn't switch off, that's inconsistent and vague, and could show up one place and then another, and could go away for a while, and then you get hopes up and then it comes back again.
Yeah.
How does that wear people down?
It's a massive issue for people with chronic pain. So common comorbidities with the abdominal pain and diarrhea, depression, anxiety, fibromyalgia, so they have sensory hypersensitivity from other parts of their body. So it's a major issue. And then there are patients who can suffer from multiple conditions at the same time. So we know of patients who can suffer from endometriosis, bladder pain syndrome, and IBS. And remarkably, they can be seeing different clinicians and different doctors for each of those conditions, perhaps unaware that the other one is existing and the mechanisms are actually common across those. So it's really difficult for the patient, it's really difficult for the clinician. And I think with more information and more research, we're starting to get to the bottom as to why this is actually happening.
What's at the core of all those conditions that you just mentioned there? What are their similarities or something that you are focusing on that might have the potential to help treat all of them at once?
Well, for us, it's really about the nervous system. It's sort of the information superhighway. It's telling us what's happening in our periphery, our interaction with the environment. So our gut, much like our skin, is a barrier to the environment, but it can sense what's going on. So we've been working on, what's been called the gut-brain axis now for the last 20 years. And really, it's how the gut and our visceral organs connect with our brain. You have all these nerve fibers within the gastrointestinal tract. Most of the time, we're lucky we don't feel what's going on inside us. We know when we're hungry, we know when we have to go to the bathroom, but apart from that, mercifully, we don't know every single thing that's going on.
Which is just as well because it's complicated.
Exactly, yeah. Whereas I think what happens in these conditions is you do get infections, you do get this sort of pro-inflammatory environment, you get rewiring of this circuitry, you get this ongoing alarm that's going off. And essentially it's sensory overload. And these different organs, whether it's reproductive tract for women with endometriosis or colon or bladder or small intestine, they're all innervated by the same nerve pathways. So they're all sending signals up to the spinal cord. They're all sending signals up to the brain. And then the brain's somehow got to interpret that. So if you think of, these nerve fibers contain lots of different proteins and which are able to allow us to detect different things. That's how we can detect hot and cold or chilies or peppermint, these sort of things. And if you think of it like a keyboard, each one of those is a key. So you can put different signals and different inputs in, and then you can understand and you can see what comes out of that. In these cases where you've got sensory overload, it's quite literally like mashing the keyboard. You've got all these signals coming in, you've got all this information, but it's essentially sensory overload, and it's perceived and detected as pain. And then you've got other processes which aren't suppressing the pain as well. So you're just driving this pro-pain phenotype, basically.
Love the analogy. So what can you do to slow down that overload or do anything to mitigate that from all that data from rushing in all the time?
So that's the crucial thing we're doing is looking at, well, what are these ion channels and receptors and what are the different types of nerves which innervate our visceral organs? Because they're actually very different to the ones that innervate our skin. There are some similarities, but they're actually pretty different. So we're working out what happens normally and what information is detected by which nerves, what receptors and mechanisms are involved in that. So that gives us a fundamental baseline of here's what should happen. And then we're looking in the disease state, whether it's inflammatory bowel disease, irritable bowel syndrome, endometriosis, etc., in preclinical models and in human samples, and saying, well, how does this all change? And once you've worked out what changes in these nerve pathways, you can then start to target them and block the things which are deleterious. So you get normal sensory sensation without the pathological pain. Because the flip side is you don't want to block pain entirely. Pain's there for a reason. So, if you've got a gut infection, you want to know that. If you've got appendicitis, you want to know that. So you don't want to block all of that. You just want to reverse what is pathological. So that's what we're doing at the moment. We've got a variety of different projects looking at how we can essentially block pain at the source. within our gastrointestinal tracts and within our visceral organs.
And have you been finding that there's consistency between one human to another in particular? Because, of course, one of the major challenges in science is that we're all different. So are you seeing that there is a lot of differences between people, or that there's a lot of consistencies in the samples that you're looking at?
I think there's both. I mean, there's consistencies, obviously, but there's obviously individual basis there as well. And at a further level of complexity, there's also sex-based differences. There's differences between men and women in terms of the way some things are signaled and transduced and the way mechanisms actually are. So from the work we've done, it might actually be that, particularly when you start looking at visceral pain, women, females, have a higher baseline sort of pain sensory signaling to start with. So therefore it takes less of an input to actually take them over to the threshold to suffer pain. And again, that's all down to the sort of intrinsic mechanisms which are there to sense what's going on in our internal organs.
How'd you get started down this path?
I think historically it's really just been a curiosity about science and the human body. As a kid, I spent a lot of time watching things such as, physicist Carl Sagan or David Suzuki or David Attenborough, seeing what's happening in the world and how it works. So it kind of gives you an inbuilt curiosity as to how the world works and, how things can change when it doesn't go well. And of course, human physiology and human disease is kind of one of the ultimate curiosities to investigate and work out. It's all absolutely crucial for us on a daily basis. As I said, when it goes wrong, that's when you get disease.
So you were set on science from a young age?
Pretty much, yeah. If it wasn't playing football or soccer, it was science. That was pretty much the way to go.
And are you still on the footy field these days?
Not as much as I'd like to. Back in the day, it was a different story, but a few injuries curtailed that one.
Okay, so we would have seen you in the AFL otherwise?
No, wrong type of ball.
Oh, okay.
Circuit, yeah.
Okay, I thought you said soccer and footy.
Yeah, the real football.
Yeah, right. Okay. So yeah, injuries cut that career short. So science was plan B then.
Well, probably plan A in reality,
Yeah.
but yeah, I wouldn't mind earning what some of these footballers earn at the moment.
Yeah, it's a bit different to the science paycheck, isn't it? So what continues to puzzle you and persist as a challenge overall in your research?
It's the complexity. And that's always been the issue is, as I said, you've got internal organs you can't see on a daily basis. You've got nerves which innervate these organs. You've got immune processes. You've got the microbiome. You've got individual human variances. You've got differences between males and females. So it's having the technology and the new techniques to actually be able to investigate that and know how that all works and crucially how it all interconnects. Not only, on the short-term basis of a few seconds, but what happens after minutes, hours, weeks, and years, because there's different processes that happen at different times which underlie this pain.
Has it changed your relationship with food and your own senses? Because I imagine you spend your whole life working in this and thinking about it. So if you're eating something you know is not great for your microbiome, or you're feeling something happening in your gut, does your mind just kick into what that could be in lots of detail?
Yeah, I think the phrase "you are what you eat" is never more appropriate. And I think that's, some of the really interesting research that's come out more recently is, things like food allergies, where they actually originate from. One of the cool studies that's been out there more recently is showing that, people who have a gut infection, as part of the immune response to that, their bodies might produce antibodies against the foods they were eating at that time. So even though the infection goes away and you return back to normal, when you have those same food substances that you're eating when you had the gastroenteritis, your body sees it and goes, well, that's the enemy, we're going to attack it. So that's why, there's lots of food allergies such as, milk, soy, gluten, these sort of things. So, there are certainly people out there who have, a personal history of gut infections or an immune process which can then shape the way they detect and also interact with food on a daily basis.
What progress have you seen made since you've been in the game that you can point to and say we're further along in this regard?
I think really it's a case of just a general understanding of how important our visceral organs are. When we started this work, 20 years ago, it was just, it's the gut, it's plumbing. Who cares about that? But I think, particularly with the explosion in, microbiome and the importance of that to human health, the microbiome is only the starting part of the process. It's how does that then communicate with everything else? It is the cells in these organs, it is the nerve system, it is the connection with the brain and backwards, which really sets everything up. So I think it's really, that's where we are at the moment. There's this greater understanding that, this isn't just the gut. It's not just all about, poop basically, and who cares about it. It fundamentally sets up our entire physiology and health.
That's certainly what I'm finding from a media perspective at SAHMRI is just about every story I write at the moment has something to do with microbiome. Yep. And that can be lifelong health or cancer or women and kids or AHE even. It's related to like absolutely everything. So it's clear that science is heading that way and understanding more and more that it is a gut brain, it is another brain, and it does have this huge flow-on effects for the rest of the body. And luckily it's so interesting because otherwise I would go a bit mad constantly writing about microbiome, but I don't see it stopping anytime soon.
Yeah, that's right. And it's important because, a lot of us think, our skin's our first defense against the rest of the world. But, what we consume, there's meters worth of gastrointestinal tract. It's the largest surface area of our body. So whatever we consume, it shapes a massive component on who we are on a daily basis and how we detect things, how we perceive things, how it sets our baseline physiological functions, our immune response to various things. So it's absolutely crucial. Mm. And as I said, I think that's the really key component I see over the last few years is just an appreciation for, what our visceral organs actually do and, what happens when they go wrong and a greater appreciation for these diseases and disorders which are out there at the moment, which afflict so many people.
And in your view, when we're talking about coming up with treatments for some of these conditions, does it all boil down to how much funding we're willing to inject into a particular disease, or is there more to it than that?
I mean, research is crucial, and that's everything from the preclinical discovery research, which is absolutely crucial to understanding, what we should then look at from a translational point of view. It's essentially the water source in the pipeline for discovery research and translational research. If you haven't got that knowledge, what are you going to translate? Now, if you think back to the COVID pandemic and, if we didn't have the mRNA vaccines, where would we be now? The amount of money that was wasted on trying to test hydroxychloroquine as an effective agent for COVID. If we didn't have the mRNA vaccines, that's where we'd be. So it's the same thing for medical research in any condition you can think of. You've got to have the understanding, you've got to have the knowledge, you've got to have an understanding of how these mechanisms work and how they change to be able to have these targeted approaches for therapeutic options to then be able to roll them out and try them in patients.
Is there a direct correlation between putting in big money into something in particular and getting results out faster?
I think so. And it's also going to be, obviously you just can't throw money at a problem without having a smart way in which to do that. But yeah, certainly without the money, then you can't do the research. So if you've got the money, you've got a great question, you're doing it in the right way, that's going to result in outcomes and results. And, that's what we've found is, we've been fortunate enough to be involved in therapeutics, which are now out there for the treatment of irritable bowel syndrome with constipation. And you can see how that mechanistic knowledge has then fed into health outcomes and improvements in patients, which, is extremely gratifying. That's what we're all here for.
Yeah, so you had a significant hand in developing a drug that's recently become available for IBS that actually can help treat a lot of those symptoms.
That's right. For irritable bowel syndrome with constipation, yeah, we were involved in working out the analgesic mechanism of action, working out how it relieves pain. So, our data was crucial as part of the FDA process for that. So,
is that the peak working with industry to actually be able to say, yeah, I had a hand in developing that drug that's now actively helping people?
Yeah, and look, when you think about medical research and we think about things from a funding point of view or a research point of view and the translation point of view, then, part of that process is working with industry as well. That's the final part of the pipeline if you're looking at a therapeutic, which someone can go into the chemist and be prescribed and take. So there's this big, long pipeline as part of that process. And I think it's knowing how different compartments of that fit together and where the expertise needs to be to ask the right questions, get the right information to then feed it in and have the best possible outcomes.
Where do you think we're going to be in 5 years? We've got things like AI growing exponentially, a lot of work being done in this area, a lot more focus on conditions like endometriosis. Things are moving faster than they ever have. Where do you see us in 5 years' time?
Yeah, I think that's one of the key processes now is to how does this all integrate together? How does it all work? Is it, substance X or substance, B or channel A, channel B, which is driving this? Can we target it? Or is it a combination of different factors? And is that different between different individuals based on their symptomatology, or is this different between, males and females? And how can we really sort of tailor this approach to treat the underlying condition? So yeah, there's a lot of room to move in this space, and it's going to be fascinating to see how this all plays out.
Do you suspect that there'll be some really solid progress in that time though, where we see more drugs on the market like we have for IBS, for some of these other conditions?
I think so, based on what is coming through, either what's in the pipeline at the moment, going through phase 1 and phase 2 studies, or things that are at a more preclinical phase. There's also the opportunity to repurpose other drugs which have already been used before for other conditions, if they're the right target for the conditions we're looking at. So there certainly is the opportunity to fast track things depending on what the mechanism is, and that's great for the patient because they've been living with pain and suffering for far too long now.
It's no small task, and all of this is a pretty intense work life. What do you do outside of work when you get some time?
Good question. I've got two young daughters, so that keeps me occupied the rest of the time.
Okay, how old are they?
They're 5 and 8.
Oh, nice. Okay, so you're busy. What do you guys get up to?
It's basically running around after them with swimming lessons and karate lessons and birthday parties and school and
staying active and eating healthy. I'm
exactly,
guessing.
Yeah.
What about time for Stu without the kids? You more of a watching soccer on TV man these days, or are you getting out and about still?
Play or kick about a while, every now and again, but it's always remarkable to see how things deteriorate and you can't do what you used to do.
Yeah.
But and how important practice is.
Bit of pain where there didn't used to be any. At least you've got a clear understanding of the process.
Exactly.
That's resulting in it. So when you look back on your career when it ends many years from now, still a young man, where do you think we'll be, and what do you want to be able to say that you were able to contribute to?
I think it's really sort of having this whole holistic approach and understanding that, the body is not just this individual organ or this individual condition. It is all linked. There's so many patients out there with chronic disease who have multimorbidity or comorbidity. They've got a lot of different underlying conditions. And a lot of them happen together. So I think that's the real crucial thing now, is thinking about, well, what is actually beneficial for our health? If we don't do that, how does it then set someone up on the trajectory for chronic disease and chronic diseases, which then is going to worsen their life, shorten their lifespan, put increased strain on the health system. So I think that's the really crucial thing for going forwards, is is really understanding that, these are crucial conditions, diseases. They don't happen in isolation. There are people out there who may be suffering from them, who don't know it yet. But it's about educating people as to, well, this is what to look out for. This is when you should go see your doctor, go get a referral to see a specialist. Because once you know what you're dealing with, then you can take active steps to basically look at treatments from there onwards. But as I said, it really is about being holistic about this and looking at how the body works together, because nothing's in isolation. If it was just the gut working alone, then there wouldn't be any pain. If it was the brain working alone, then it wouldn't, detect what's going on in the gut and vice versa. So it's really taking this multi-system, broader approach and working out the complexities from there.
Sounds like an infinite problem. I'm glad we've got people like you working on it, because it is so relevant to so many, and so many of us are desperate for outcomes now and will be in the future. So keep at it.
Thanks very much, and let's hope the funding continues.
Let's hope the funding continues, that's right. Thanks, Stu.
Thanks, Callum. Cheers.
If you want to learn more about SAHMRI and the researchers working to build a brighter, healthier future for you and your family, head to samhri.org.au.